First speaker is Marcia Tan, who is an assistant professor in the Department of Public Health Sciences at the University of Chicago. She has a background in clinical health psychology and epidemiology, and her work focuses on health disparities in modifiable cancer risk factors, including tobacco use, obesity, and she focuses on cancer prevention among underserved populations. Her specific interests are around examining biopsychosocial behavioral factors that contribute to disparities in cancer. And she's really interested in conducting community-based health behavior interventions to reduce risk factors among disparity populations. So she's really on the ground interacting with people, community health workers. Her training is from, she has a PhD in clinical psychology from the University of Miami, an MPH from the Rollins School at Emory, and a BS in psychology from the University of Alabama, Tuscaloosa. And she also did postdoctoral training at Northwestern as well. So Dr. Tan, we'll wait for your slides, but welcome.
I feel like I should tell jokes while I'm waiting. I won't though. Okay, here we go. All right, thank you for the introduction, Albert. Again, my name is Marcia Tan. I'm in public health sciences. And just to, there we go. All right, so what I'm going to talk about today is I'm going to kind of zoom in and talk a lot about the provider and the patient interaction and communications there, and really introduce a workforce, community health workers that are really designed to bridge communication between the healthcare system and patients. I'm going to present two studies today, focusing on the qualitative research from those studies to really, go ahead. We're not ready? I am so sorry. All right. Hello. My name is Marcia Tan. Thank you for the introduction, Albert. I will be diving in and talking more about the patient-provider interaction today, really highlighting community health workers as a workforce who's really designed to bridge communication gaps between providers, the healthcare system, and patients. And I'm going to present two studies today, focusing mainly on qualitative work to really get a better understanding on what's happening in those interactions with patients. And, you know, we already went through my background, but I just like to put up this slide to mention that I am a clinically trained health psychologist with also a training in epidemiology and public health. So I really like to take the understand the individual approach and individual interaction with public health interventions. And that's kind of the framework that I use to do my work. All right. And so a little background is that my work is in cancer health disparities. And I like to put up this slide just to show that disparities exist across the cancer continuum, from prevention all the way to treatment and survivorship. And you know, looking at disparities, you see people with low socioeconomic status, low resources, really bear the burden of cancer. And so you really think about how to treat these populations. You really have to, it's very complex, the issue of cancer health disparities, or health disparities in general in this country. I always put up this chart to show, this is from the National Institute of Minority Health and Health Disparities, to show how we should be thinking about conducting research to really eliminate disparities and improve health equity in this country. And you can see, you know, there's a lot of levels of influence that we need to address, but also domains of influence. And I think traditionally in research, we really are focused kind of on one little cell and one little box, but they really are, you know, charging us to think across all of these levels and domains to develop multi-level interventions to really address disparities. And so today, why am I not changing? There we go. So I'm going to be focusing on the healthcare system and really talking about some research that kind of cuts across multiple of these levels of influence. And so I don't want to go further before I discuss the issue of medical mistrust, which is a big issue, and also why community health workers exist as a workforce. And so just to orient everyone, when we talk about medical mistrust, we're talking about general distrust in the healthcare system and health providers to really provide and health for patients. And this is something that is not inherent to a patient. This is a natural result of recurrent systemic discrimination and racism over time, particularly seeing among minoritized individuals such as Black Americans. And I just like to mention that this is, again, it's not inherent. It's something that, has been developed over time, and individuals really respond differently. And so individuals have different levels of medical mistrust as well. So it makes you, kind of think about how can we address this? How can we build trust again in the healthcare system? And this is important because we see that patients are more likely to adhere to treatment or respond to engage in treatment or follow doctor's orders when they do have trust in this in their medical providers. And so thinking about how do we build trust again? How do we work to build trust? Community health workers are actually a workforce who are designed to act as a bridge between the healthcare system and the community members. And this is the official community health worker definition from the American Public Health Association website. And community health workers are really the frontline public health workers. They're trusted members of the communities they serve. So they oftentimes come from the communities they serve. So they really have these ongoing trusting relationships with patients. And they really wear many, many hats. And so community health workers, the community health worker model has existed for decades, especially globally, not just nationally. And they are increasingly engaging in more health education, doing behavioral intervention, lifestyle risk factor interventions and things like that. They also exist as patient advocates and really just addressing some of the social determinants of health that patients that might act as barriers to patients receiving care. But specifically, they really build trust and develop trust and maintain trust over time with patients. And the role of community health workers was officially recognized as part of the healthcare workforce under the ACA in 2010. But unfortunately, recognition does vary by state. In Illinois, we don't have a standardized training process or a standardized certification for community health workers, but we do have an advisory board that's really working to think about how to grow and sustain this workforce. The next two projects I'm going to talk about are specifically with community health workers and how to train and integrate community health workers into care, really thinking about how to provide care to under-resourced populations that might not have access to care, or if they do have access to care, there's a disconnect between their goals and maybe what the provider's goals are. So the first project is more on the cancer treatment side of things to really understand advanced care planning among Black women with breast cancer. This is my wonderful lab. I just wanted to shout them out. They've done a lot of work with this project, especially with coding and analyzing the qualitative data. And just to give an introduction to advanced care planning. So advanced care planning is a process where patients really develop and establish their goals of care, particularly in times where they're not able to make those decisions later on. And the idea is that these goals are recorded in written documents. And so you might have heard of like a living will or establishment of a health power of attorney and other like orders like do not resuscitate or do not intubate. This is all in the realm of advanced care planning. And advanced care planning is actually a very, it's a longitudinal process. So it's not just one time, a patient is asked to, make this decision, which actually occurs like that, often, but it's really designed to be a conversation where working with the patient to understand their illness or, treatment, and to develop goals that can later be, codified in these documents. And there are a lot of people who can be involved in this process. It could not just be the physician, although it often happens in clinic appointments. It could be a nurse or, people in community health practices, the actual person itself. So it's a multifactorial process, and communication is very important with advanced care planning. But unfortunately, the rates of ACP generally are very low, particularly of ACP being documented with patients. And there's a lot of different factors that contribute to this. And then we also see disparities, particularly with minoritized groups. And this could be individual level factors like a patient not having education about what ACP is, or even conflating, having a conversation about ACP with hospice care, or that they're at the end of life. But also could be system level factors, such as the, systemic, discrimination that we've talked about previously, or just the lack of standardized training and the limited ACP training for providers, and also for other people who might be involved in this process. So particularly, we're interested in understanding ACP in Black women with breast cancer. This is a group that we've seen to have worse outcomes. They tend to have be diagnosed with more aggressive types of cancer and at later stages. And so, ACP, timely ACP is very important part of their cancer management, but you really see very, very low rates, particularly of the patient-provider discussions about ACP. If you look at Black patients with advanced cancer, even when they express their interest, they're less likely to receive care that's concordant with what they want. So this is definitely a population we need to think about. How can we improve ACP? ACP is extremely critical with Black women with breast cancer. So I did not advance my slides. So going back to who should be having this conversation, we actually found that there are very few patients with advanced cancer who actually are interested in having this discussion with their oncologist, and an oncology appointment is often the time, especially those with diagnosed with advanced cancer, where these happen. And so that's why it's very important to think about building trust with these patients and having ACP conversations in a very clear, concise manner that's also culturally sensitive and relevant to the patient. And so we were really interested in thinking about community health workers as a way to integrate community health workers into this process to really, spark these conversations and have these conversations with their patients, to really empower their patients to have them with their providers as well. And this study actually was introduced to me by a community health worker who was involved in some of my other research. We were asking about what they might need for training, and they were like, advanced care planning, definitely. This is something that comes up often. The CHWs who are embedded within healthcare systems, but they don't feel equipped to really have these conversations with the patients. And so our objective really was to understand ACP, implement documentation in the UChicago system, and to understand how to improve this with Black women with breast cancer, and then with the goal of developing a CHW training that will be accessible to CHWs to improve their knowledge and confidence in ACP with their patients. So this is our framework. So the issue of Black women with breast cancer not having high rates of ACP with their providers. CHWs can act as that bridge. So we first want to do a needs assessment to see what do CHWs know about ACP, what they need as far as training, and also to examine, as I mentioned, the current practices of ACP, and talk to providers to really understand what might be barriers with them with having these discussions with Black women with breast cancer. So this is a mixed method study. I'm only going to present the qualitative data today, but we did do a pool for electronic health records to see how often it was documented. And then we also ran focus groups with CHWs and providers to really get a better understanding of the the process and the practice of it. And the idea is to really understand and develop strategies to integrate CHWs into this process and to having these ACP conversations with the final goal of developing a comprehensive training for them. All right, so as I mentioned, we ran focus groups. We had 2 focus groups with CHWs and with providers. So these were small data, but we had 5 CHWs. We realized that most of them did not have any experience working with cancer or in an oncology setting, although they were having patients who had cancer, who were dealing with cancer treatments and things like that. And then we also had 6 providers that range from radiation oncologists to medical oncologists. Most of them all of them received some kind of prior training in ACP, but it could have been formal versus informal. And all of them reported primarily serving Black women with breast cancer. But they also reported that they had lower rates of ACP documentation within their own practices. And so what we found was that for CHWs, they really talked about the lack of training and the inaccessibility of that training. So the trainings that exist right now are very long and costly. They cost a lot of money that CHWs don't usually get reimbursed for. They also talked about patients' reluctance to have these conversations. They talked about CHWs were unclear about whose responsibility it was to have these conversations and particularly document ACP. So they, mentioned things like, we don't want to step on anybody's toes, like we don't know what we're supposed to do in the situation. And then generally the lack of knowledge about oncology and kind of knowing where a patient is in their different stages of their treatment or their disease. And for the providers, they did acknowledge that there is this medical mistrust with their patients, and the patients are more reluctant to have that conversation, also acknowledging the physician-patient power dynamic that made it, not easy or more awkward to have the conversations. And then the bigger theme was, or the major theme was that providers had competing priorities, especially they were focusing on, it depended on the stage of diagnosis for the patient, depended on the treatment. And some of them acknowledged that there was a stigma around having the conversation because they didn't want the patient to feel like they were giving up on them, or that, the patient, that they had failed in treating the patient. So, and they also mentioned that that when they felt that they were ready to have ACP conversations with their patients were not ready, and they had different priorities and values at that moment. And so thinking about, paying attention to the inside of the Venn diagram of, what makes a successful ACP conversation, both providers and CHWs acknowledge that starting early, so not having this at the moment of diagnosis or, at the moment, just the idea that it's something that's normalized over time. And then having that this is an ongoing relationship that involves multiple providers, involvement of stakeholders like family members. And also it's really about aligning the patient's goals and wishes as well. So I'm going to present a few quotes about kind of thinking about what we need to think about as far as the patient and the patient's experience. One of the, just read off my paper here. So one of the providers noted that, we have to consider the individual's culture rather than looking at African Americans globally. We have to look at the individual's cultural perspective. And they also, acknowledge the historic injustices that some of their patients are experiencing. Quote, when anyone is treating someone of a particular group that has had social injustice, you have to overcome that barrier before you can get to we have this disease process that we're dealing with. And they also noted that there are a lot of misconceptions about what palliative medicine is or supportive care, where they conflate palliative care with hospice. You get well, that means you're giving up on me. And also, building trust as a process. So the CHWs noted, like, we're their eyes and we're their ears, and we build a trust and relationship with their patients. And then, notably, that, the patient themselves like has different goals. The priority of ACP might be number 7 on their list when they're still taking care of their families or the main caregivers of their families. And one provider noted, I'll also have older African-American women that despite the fact that they're 75 are still the main caregiver for their family. And, the support kind of goes the other way where they're supporting their family rather than the other way around. So just for time, I'm going to not going to read all of these quotes, but I just did want to, highlight some of the ways that CHWs thought about improving ACP is, the time of the discussion, having it earlier, having it more routine, and then thinking about and just listening to their patient and kind of like seeing where their patient is, they can really help align the patient's goals. And then also, the CHWs specifically are very unique and they really can support the ACP process with their patients because they are working on developing this trusting relationship with their patients. And, finally, what we found is that CHWs really need to be trained in ACP, but they really are a workforce that really will help directly, bridge this communication gap, start this communication process over time so that ultimately the patient's goals are aligned and also they receive care that's concordant with their goals. All right, so the last study I'm going to kind of briefly go over is some of my main research on tobacco, which is we're going to go back to the cancer prevention side of things and understanding, okay, when patients aren't in the system, how do we get treatment out to them? And so we know that tobacco cessation is still an issue for those with low resource. There's still high rates of those with low resources, low SES, low education. And although we've seen a decline over time, we still have a population that's continually smoking. And, these patients aren't actually receiving treatment. So even when they do go to receive treatment, like in a primary care setting or in a clinic-based setting, they really aren't receiving advice to quit smoking. So this is where this project came from. And our overall goal is to really thinking about community health workers and knowing that community health workers see these patients more often face-to-face. How do we adapt a tobacco cessation training for them that will increase their knowledge and confidence and therefore equip them with the tools to deliver tobacco cessation to their patients? And the long-term goal is to develop a scalable intervention or a scalable training for CHWs. This is just a general overview. It's a very wordy slide of the project. And so we really are taking an iterative process to develop a tobacco cessation training for community health workers. And we're concurrently running focus groups at each stage to understand, where we are in the process. Does this training make sense? And what we need to consider when we think about community health worker interactions with their patients. So we started off doing a needs assessment survey to get a sense of if CHWs are doing tobacco cessation at all with their patients. Do they want tobacco cessation training? We did the survey in Spanish and English. And then we also followed up with a focus group to get better understanding of the nature of interactions they have with their patients. And also just general tobacco services and what they would want in a training if we developed or adapted a training for them. And what we found is that, CHWs have a great amount of flexibility in their care. I think I was trained, as a psychologist to, deliver a very structured intervention, let's say on tobacco, like an 8-session intervention over a 4-week time. But, for them, they don't see their patients in this 1, hour, like every Monday. They kind of respond to their patients' needs. And they also, in that sense, they see them in a lot of different places. They might see them in their home. They might see them at church. They might see them at a restaurant. And then so therefore, they kind of have this ongoing, care with their patients. So if the first, visit they had a discussion about, just trying to figure out how to fix the thermostat, in their living room, then the next visit they might bring up managing their diabetes or whatever it is that they're there to talk about. And then we also found that how the tobacco cessation curriculum, like the facilitation trainings that exists right now, don't really fit with this flexible care model. And this is also important because a majority of their patients do smoke. And in the 6-person focus group, we asked directly how many of your patients smoke on average. They were like 99%. And we were like, they're like all of them. We were like, no, how many? They were like 99% of them. And so that was telling that they do have this group that does need treatment, but they also don't have the knowledge to treat tobacco use directly. And so what we followed up with after this needs assessment, we took that those data to develop an outline of adapting a WHO like brief counseling toolkit to help people quit smoking. That's really designed for primary care providers, and we adapted it according to the CHW care model and what we were the data that we received. And what we found, and so we developed this outline. We ran focus groups to get feedback on actually like a draft of a training that we would give and based on this outline. And what we found mainly is that the 5 A's model, which is designed to ask patients about quitting, or ask patients about smoking, see if they want to quit, and then, advise them and kind of assist them with quitting. They were like, that's great, but that doesn't really work because none of our patients are motivated and ready to quit. And so they were like, we really need to think about motivation for helping our patients quit smoking. And then also that, patients are dealing with recurrent stressors, so quitting is not always on the top of their minds. And then so we really want to understand how to personalize information, how to integrate that in, the chronic disease care that is like the priority for a lot of their patients. And again, for sake of time, I'll probably just, read one of these quotes. Is that, just notably that smoking is a stress reliever, and we really need to, if we're going to take away smoking from them, one of the CHWs were discussing, how do we replace it with an adaptive coping strategy? Because we can't just leave them with nothing. And so, they noted a lot of young people tend to smoke, especially in our community, because of stress, because of the things that they may lack in the communities, or, if it's a lot of violence going on within the Black communities too. So it's something that, we're thinking about as we're developing this. This is a little bit different. Some of the basic tobacco cessation trainings have things like identifying triggers, figure out, ways to, get through a urge to smoke. But a lot of the examples are standard, like go take a walk. And like for a lot of these populations, that just doesn't make sense, or that doesn't, that can't happen in the neighborhoods they live in. So just to follow up, for the ACP study, the conclusions really are that, CHWs really, can help support ACP conversations with their patients because of their ongoing trusting relationship with patients. They really can help serve between this communication bridge between the provider and the patient, but they really need training and to really to increase training in ACP in the process, but also in the context of cancer care, oncology terms. And then for the second study, the take home is that the CHWs need, a curriculum that really fits with their flexible care model and that's relevant to the disease population that they serve. And so we're working to develop a training for that we're actually running this week. I'm very excited about. And we've done a lot of including culturally relevant material in the training, such as like the tobacco industry's targeting of Black communities to smoke menthol cigarettes, for instance. But then we also are focusing on skill building for motivational interviewing, specifically to take a patient that they might see with that might have tried quitting in the past, but is unmotivated because of all the other things going on, so they can actually practice doing motivational interviewing, refresh their motivational interviewing skills, and practice with those patients. All right, and I want to acknowledge all the CHW organizations that have worked with us throughout for this project and are continuing to work with us. And I don't know if I have time for questions, but thank you for listening. Probably not, right?